Thank you very much, Jihad, for this kind introduction. Thank you for Emirates for inviting me to join them in this scientific meeting. And thank you for Sanofi for having me for this symposium. So today we're going to discuss teriflunomide in clinical practice, all aspects of teriflunomide. These are my disclosures. The presentation will cover first the mechanism of action, which I think is extremely important in explaining the safety of the drug, the efficacy measures of Obagio, the efficacy in the extension studies on the long term, safety and tolerance, the pregnancy issue with teriflunomide, and finally, teriflunomide and the COVID-19 pandemic, which is the hot question everybody is asking today. How to use Obagio in the COVID-19 pandemic? So the mechanism of action, as you know, the regularly dividing lymphocyte in a normal state, usually you use the pyrimidine salvage pathway to synthesize their own DNA. The dihydroorodo-dehydrogenase enzymes carries a second pathway, a parallel pathway, which is not used at rest. However, once there is an active inflammation like MS, the lymphocytes start dividing very rapidly, and then the salvage pathway is not enough, and they have to use the DHODH pathway to proliferate quickly and faster. And this is where teriflunomide works. So Obagio basically will inhibit this enzyme and decreasing therefore the lymphocyte proliferation, leading to a mild decrease in the number of lymphocytes. So this is the basic mechanism of action. However, once it does that, remember, the pyrimidine salvage pathway is still ongoing. So the lymphocytes are able to proliferate regularly to defend against infection, viruses, bacteria, malignancies, but not quickly to induce inflammation. And this is really the basic importance of this mechanism of action to explain the efficacy and at the same time, the safety of the medication. So basically, because of that mechanism of action, the lymphopenia is very mild with teriflunomide or Obagio. It's around 15% decrease in the lymphocyte count, but it's always above the upper limit, the lower limit of normal. And the same also for the neutrophil count. It's always above the lower limit of normal, although it's slightly decreased. Lymphopenia, severe lymphopenia is very rare with Obagio. It occurs grade 3 lymphopenia, which means a lymphocyte count below 500 occurs in around 2% of cases only, and grade 4 lymphopenia in only 0.2%, so extremely rare. Neutropenia is reported in around 6% of the cases. At the same time, and because of this mechanism of action, there is no increase in the serious infections with teriflunomide. If you look here between the core studies between teriflunomide and the placebo, the incidence of serious infection is 2.5%, so similar to placebo. The incidence of malignancies is also similar to placebo. So no increase in serious infections, no increase in malignancies, and of course, no PML cases so far with Obagio. And remember that some studies have shown that actually Obagio might have an antiviral effect, so maybe an antiviral effect that might fight the JCV virus. Because of all of these findings, that it does not deplete lymphocytes completely, allow them to still proliferate, because it has no increase in serious infection, no increase in malignancy, no PML cases, mild lymphopenia. Because of all of these findings, the European Medicine Agency labeled teriflunomide as an immunomodulatory agent, not an immunosuppressant agent, which is, of course, again, a very important label for us to talk about the long-term safety of the medication. Now, once you consider a DMT selection, a patient comes to you and you want to decide, what are the things that you think of? Number one, you look at the patient's prognosis. Is this really a very bad MS with very poor prognostic factor, high relapse rate, severe disability, high lesion load? Or is it a mild MS with good prognosis? Once you decide on that, the first goal of your treatment is really to achieve efficacy. So you want to decrease the relapse rate, disability progression. And this is where the safety comes in. You have to weigh the risk of the treatment. So the higher the efficacy medication, the more side effects, versus the prognosis of this patient. So shall I use a mild medication with moderate efficacy but low side effects? or no, this is a bad prognosis case, I have to go at the high side, a high efficacy medication with some more side effects. So this is the main decision. Also, two more factors come into your decision. Number one, tolerance and the patient lifestyle and quality of life. You don't want to use a medication that will induce a lot of adverse event, has poor tolerance, and therefore will affect the quality of life of. And finally, you want a medication that's tolerated enough by the patient to be adherent. And adherence is a major problem in MS nowadays. So these are the things you would think of when you're deciding on starting a treatment for an MS patient. So let's look now at the patient profile for Obagi. What's the typical patient profile? The first profile are the patients that are treatment naive. And usually it's a patient that has the good prognostic factor. So like a young woman with an optic neuritis or a sensory attack with a good recovery, a low relapse rate, not a very high MRI lesion. That would be the typical good prognosis case and treatment naive. That would be the typical first profile for Obagi. The second profile would be a switch, a patient who is also that has MS, it's well controlled on interferon, but has a poor quality of life due to the injection site reaction, the flu-like syndrome. So the tolerance issue here, and this would be the second ideal profile to shift this patient to Obagi. So these will be the two typical profile where I would use Obagi in my practice. So Obagi has been studied through three main studies. The TOPIC trial, which was for CIS patient at the time, but using the 2005 Magnolia criteria. So most of those patients now are basically early RRMS. And finally, the TEMSO and the TOWER trials, which were RRMS patient randomized controlled trial versus placebo. So let's start first by the first question the patient will ask you is about efficacy. Is this drug going to be efficacious? Will it decrease my relapses? Will it prevent disability? Let's look first at the efficacy data. So in the TOPIC trial, which remember were CIS or by nowadays early RRMS patients, after the 2 years of the trial, there was a 43% relative reduction in the risk of a second relapse, which is conversion to clinically definite MS. So 43% reduction in the risk of a second relapse. If you look at the TEMSO and the TOWER trials, again, we can see 32 and 36% reduction in the risk of relapse versus placebo. So this is a medication with a clear moderate efficacy in treating MS. At the same time, in both TEMSO and TOWER trials, terflunomide was also effective in reducing the severe relapses. So relapses requiring IV steroid, relapses with residual disability, relapses leading to hospitalization, and all of those, we can see a statistically significant reduction in the risk of those relapses versus placebo. Disability in both trials, the TEMSO and the TOWER, disability was reduced by 30 to 32% versus placebo. And remember, until today, this is the only oral therapy with continuous treatment that has shown consistent reduction in disability in both trials. Now, so as far as the treatment goes, the efficacy, we see this is a moderate efficacy medication that has been shown in multiple trials to have a reduction, to induce a reduction by around 1/3 in disability, by around 1/3 in relapse rate. Now, how about cognition and brain atrophy? The patient will always ask you, I might have a problem with memory. I've read that MS can affect your cognition. Will this medication help with cognition and with brain atrophy, which are, as we know, very strongly correlated? So let's look at the data here. In the original TEMSO core studies, the PASAT was used as a measure of cognition. And at the end of the trial, at the end of 2 years, there was a significant improvement, as we can see here in the PASAT score in patients on terflunomide 14 milligram, while the patient on placebo had actually worsening of their score. So there was a statistically significant effect on cognition. And this effect actually was maintained in the extension trial. When we look at 252 weeks, which means 5 years later, still you had a further improvement in the cognitive score compared to baseline, and whether it's at the C or the RO score. So up to 5 years, Obagi is still showing a persistent improvement in the cognitive score. And at the same time, The TEMSO trial had with it the MRI data, and it showed that at the end of 2 years, there was a 30% reduction in brain volume loss. So both brain volume loss and cognition are both improved actually with Obaju up to 2 years, and cognition we've seen up to 5 years. So it has an effect on both factors. Now, the second question will be from the patient, what happens in the long term? So what is the long-term efficacy data for Obaju? Will it keep controlling the relapses, the disability, the MRI activity on the long term? So the original topic and TEMSO trials, after they had a placebo arm, a 7 milligram terfenol arm, and a 14 milligram, but the currently approved dose here, at least in our area and the Middle East, North Africa, and Europe, is a 14 milligram. So after the 2 years trial, all patients on placebo were shifted to teriflunomide to either doses, while the other patients on teriflunomide were continued. And there was a follow-up up to 7 years for the topic and up to 10 and a half years for the TEMSO. So we have data up to 10 and a half years as far as efficacy is concerned. For the Tower trial, they were all shifted to 14 milligrams, so there was no 7 milligram in the extension, and the extension was followed, patients were followed up to 5.5 years. So these are the three trials with a long-term follow-up between 5 and 10 years for the patient. And if you look here at the long-term, the topic, remember we had a 43% reduction in relapse rate at the end of 2 years. And this is here at the end of 5 years, we still had a persistent difference from placebo with a 47% reduction in the risk. If we look at the TEMSO and the Tower, the combined data, remember we had a decrease in the relapse rate initially. And if we look at the relapse rate 10 years later, we can still see here that this control is still persistent with a low relapse rate 10 years later. The same for the EDSS, a stable EDSS over 10 years for all the patients that were followed for the TEMSO and the Tower. And finally, for the MRI activity, this is the placebo here, and this is Obaju. Of course, the placebo had high MRI activity during the first 2 years, but then at 2 years, all patients were shifted to Obaju, as I mentioned. And if you look with the follow-up here, up to 7 years, we can see that there was a very good control as far as the MRI activity is concerned. No new MRI lesions, basically up to 5 years. So the long-term data is showing that this efficacy is maintained for a very long time, whether on relapses or on MRI activity. The mean lymphocyte count also stays stable. So this mild 15% decrease in lymphocyte count does not worsen with time. Actually, it stayed the same and it's stable. And this is another reassuring thing as far as the long-term safety of the medication. Even with the long-term follow-up with Obaju, and we're talking about almost 4,500 patient years, there were no cases of grade 3 or grade 4 lymphopenia, and 94 of the patients actually did not have any lymphopenia. So as I mentioned before, it's an immunomodulated, not an immunosuppressant, as lymphopenia is not really an issue with the medication. Now, as far as safety, if we look at the basic trials, they combined the patient, almost 1,000 patients from the original trials, the phase 2, the TEMSO, the Tower, and Topic all put together. And we can see that the serious adverse events are not very dissimilar between teriflunomide and between placebo. Even if you look at the severe adverse event here, we can see that the percentage 14% and 14% is quite similar, and the deaths are similar. So actually, it's safe enough to the point that it's actually not different as far as adverse event profile from the placebo arm. And if we look at the long-term extension studies, as I mentioned, we followed them between 5 and 10 years, again, comparing placebo to teriflunomide in the TEMSO and the Tower trial. And again, we can see that if you look at the serious adverse event here, 21% and 24% between placebo and teriflunomide, and we can see here 6 and 12%. So if you put them together, not a very significant difference between the placebo and the Obaju arms, and the same for this. So even on the long-term extension trials, we didn't see any new alarming sign of a new adverse event or a serious infection or an opportunistic infections or PML and actually the number were still similar to placebo. Now, another question that will be asked by your patient is how bothersome will this medication be to me? Will it have a good tolerance? Will it bother me? Will it affect my quality of life? Will I be able to adhere to this medication? So question is asked very frequently, especially from young female who are most of our patients. So is there any real world practice evidence to look at the tolerance of Obagio? And the answer is yes. The TerryPro trial actually was a trial that was designed specifically to check the quality of life of patients and their satisfaction with Obagio. So patients that were entered at baseline, around 1,000 patients were followed for a full year and were administered the TSQM, which is basically a quality of life questionnaire that report patient-reported outcome, the PROs. And interestingly, if you look, for example, at the patient that shifted from interferon to Obagio, usually due to tolerance effect, and we look here at the global satisfaction, interferon in gray here, and Obagio in brown, and we can see a significant increase in the satisfaction score once shifted from interferon to Obagio by the patient. And this increase is specifically guided by the side effect, which the satisfaction side effect increased significantly, and by convenience. Rather than taking an injection every other day or daily, you're getting here a single oral tablet per day. So the side effect and the convenience were the main issue that have driven a much higher satisfaction with Obagio once shifted from interferons. And the same actually with cletirimer acetate. If we look at dimethyl fumarate, sometimes you get side effects with dimethyl fumarate, like GI intolerance, like the flushing, and sometimes they are bothersome. So shifting from dimethyl fumarate to Obagio actually led, you can see here, a significant increase in the global satisfaction in patients. And this was again driven by an increase in the satisfaction regarding side effects, so much less side effects, and much better tolerance with Obagio, and an increase in the convenience. You're taking one tablet a day versus two tablets. If we compare it to patients shifting from fingolimod, there was no difference in satisfaction. Both medications are well tolerated because they are both a single oral treatment a day, and fingolimod side effect is also very low. So there was no statistically significant between the two. But of course, remember, fingolimod is an immunosuppressant and has a different risk profile than Obagio. So the tolerance of Obagio, I think, as I've shown, is excellent, especially compared to other medications. Now, let's face the issue of pregnancy. Now, as you know, Obagio has been shown in animal study to be teratogenic. However, when we use it in humans, there was no evidence of teratogenicity. Terflunomide is the main byproduct of leflunomide and the main active ingredient of leflunomide, which is Avara, which has been used in rheumatology for more than 15 years now. And again, the pregnancy registry of leflunomide in humans, again, does not show an increase in congenital malformation. So finally, last year, the terflunomide pregnancy registry was published. We had a total of 437 confirmed terflunomide exposed pregnancy. 222 of them had known outcome. And if you look here, the rate of congenital anomalies on terflunomide was only 3.6%. And remember that in the general population, the rate of congenital anomalies is 2 to 4%. So the rate of congenital anomalies with terflunomide was similar to the general population, as was the rate of spontaneous abortion, which was 10%. And again, in the general population, the abortion rate is usually up to 21%. So again, we are seeing that in a human, we are not really translating the teratogenicity that we've seen in rat and mouse. Why is that? The reason is the following. The dihydrooroto-dehydrogenase enzyme, which is the main enzyme that is affected by terflunomide, is more sensitive to the drug in mice and rat than in humans. And actually, if you look here, the anti-proliferative effect of terflunomide was approximately 140 times greater in rats than in humans. And this probably explains why at the same dose, kilogram by kilogram, the drug was teratogenic in animals, but not in humans. Of course, it's not enough to change the label yet. We're going to need more cases But hopefully in the future, this label will change regarding the safety of teriflunomide in pregnancy. Now, we come now to the hot question regarding the COVID-19 pandemic. What do we do during the COVID-19 pandemic, and what is the role of teriflunomide? Is it safe? Now, I was member of the scientific board of the MS International Federation, and we published our guidelines regarding how to use a disease-modifying therapy during the COVID-19 pandemic, and these were the most recently updated one few weeks ago. So basically, if you look here at the category of teriflunomide, same for dimethyl fumarate, fingolimod, ciponimab, and natalizumab, the evidence available suggests no increased risk of more severe COVID-19 symptoms. Same for the interferon glatinoate acetate, and actually, some studies have shown that the interferon might reduce the severity of a COVID-19 infection, probably due to their antiviral effect. The anti-CD20 therapies have been shown to increase the severity of the infection in many studies. And finally, anatizumab and cladribine, we don't have enough data regarding them. But as you remember, they both induce a transient lymphopenia. So probably the best way to do is that the drug will be safe during the periods when the lymphocyte recover, but not during the period when there is a significant lymphopenia, especially grade 3 lymphopenia. So to go back to teriflunomide, it's safe to use during the pandemic. It does not increase the risk of catching COVID-19. It does not increase the severity of the disease. The second question is the vaccine. Can I take the vaccine for the COVID-19 while I'm taking teriflunomide? And the answer is yes. We know already that some disease-modifying therapy decrease the efficacy of the vaccine, specifically fingolimod and the anti-CD20 therapies because of their effect on the B lymphocyte, which decreases the propensity of those cells to produce the antibodies needed for the immunity. So as I showed already by the mechanism of action, teriflunomide has a minimal effect on lymphocyte. The salvage pathway is present all the time, so they are able to proliferate to fight viruses and bacteria. And the lymphopenia with teriflunomide is very low, only a 15% decrease in lymphocyte. So based on that, Teriva was a study that assessed vaccination in patients on teriflunomide. And as you know, the standard for vaccination is to achieve a high titer of 40 in at least 70% of the patient. And I put here this mark at the 70%. And these are number of patients that were vaccinated on teriflunomide for different type of flu vaccines. And we can see that just like the interferon, patient on Obaju reached the 70% mark for all types of vaccine. So again, vaccination is going to be effective against viruses with Obaju, just like with interferons. And there is no need to stop the medication or withhold it once the vaccine is being taken. So in summary, teriflunomide significantly reduced the risk of relapses versus placebo, as we saw 32 and 36% in the TEMSO and TOWER, and around 43% in the TOPIC. Teriflunomide is the only oral DMT to significantly reduce the risk of disability worsening in RRMS patients in 2 pivotal studies, the only one that consistently showed this effect in both studies. Finally, teriflunomide has an effect on the blood volume loss. It decreases the blood volume loss by around 30% in the original trials. And it has an effect on cognition, improving cognition, and this effect is maintained even in the extension trials. Finally, the efficacy of Obaju, as we show in the TEMSO and TOWER extension trials up to 10 years, was actually maintained as assessed by relapses and by MRI activity and disability. And finally, and one of the major attributes of Obaju is that it's a very well-tolerated medication. It's very easy to use, 1 tablet daily, and it achieves usually some of the highest scores in patient satisfaction compared to other DMT, as I've shown in the TeriPro study. Finally, our Minectrim guidelines, we published an update early in the 2020, and because of all these data, the moderate efficacy, the very good safety, the fact that it's an immunomodulator, not an immunosuppressor, and the fact that it's highly well tolerated by patients, this is why teriflunomide in our Minectrim guideline is used as a first line and is also used when shifting from the injectable or even dimethyl fumarate due to side effect. And as I've shown, the satisfaction of the patient increases significantly once shifted to teriflunomide if they are having side effect on the other DMTs. Thank you very much.